HDRN Canada, or Health Data Research Network Canada, is a pan-Canadian nonprofit distributed network organization. Our mission is to bring together people and organizations across Canada for transformative and world-leading health data use. Our vision is to utilize data across Canada to drive improvements in health and health equity. And our values include collaboration, trust, creativity, excellence, and respect. Next slide. So at a glance, HDRN Canada is composed of several components and initiatives, namely our Data Access Support Hub, or DASH, which is our one-stop data access service portal for researchers interested in pursuing multi-regional health and health-related administrative data in Canada. And DASH provides a streamlined process for researchers through a centralized data access request form and harmonizes the process to request data from multiple data repositories. Other initiatives include examining common data models through pilot work to work towards rapidly harmonizing data and further enabling multi-regional research, supporting Indigenous data sovereignty through supporting Indigenous-led uses of Indigenous data to advance reconciliation, the Pragmatic Trials Training Program based at the University of Western Ontario, which equips researchers with skills to work towards pragmatic trials. Also, public engagement, including collaborations, publications, and events to support public and patient engagement. Data privacy tools. So this is resources that are available for conducting privacy-sensitive research on administrative data. And also our work on inclusion, diversity, equity, and accessibility, or IDEA, in order to develop guidance for purposeful action towards overcoming barriers within data systems and research structures. I'm sorry, just that you can see some of the numbers of HDRN Canada there. There are 574 data assets and numerous other indicators as well. Next slide, please. So the HDRN Canada network is comprised of many organizations, including pan-Canadian data stewards like CIHI and Statistics Canada, and our data centers, which represent each of the provinces and territories. Next slide. HDRN Canada is also dedicated to strategic engagement and partnerships. We engage with a variety of partners, including publicly funded researchers, charities and nonprofits, for-funded entities, the public, research entities, government, Indigenous communities and organizations, as well as the private sector. We engage for numerous reasons, including to source and steward data, translate and share knowledge, foster the data policy ecosystem, and to promote use of data for multi-regional studies. And we do this through many means, including forming strategic engagements or more formal partnerships, service provision, advisory roles, including giving and receiving advice, and enabling others in their initiatives. We also strive to measure success, including fostering partner satisfaction, working on collaborative deliverables, supporting our partners' organizational goals, and advancing health and health equity. Our most recent initiative in this area is the Health Data Research Alliance, or HDR Alliance, which is a forum with various organizations to work collectively on areas of shared interest. Thanks. And now I would like to pass it over to Dr. Vicki Kirsch to talk about CanPath.
Great, thanks very much, Jody, and hi everyone. Thanks so much for joining. So I'll be talking about the Canadian Partnership for Tomorrow's Health, or CanPath. Sure, next slide. I'll be talking about the ways that CanPath can be integrated with administrative data holdings to serve as a resource for health research. So CanPath is Canada's largest longitudinal cohort study, and it was designed to assess an extensive range of exposures to really a wide range of health-related outcomes over a long period of time, but it can also be used for health services research. It's really a resource for studying the biology, behaviors, environments of Canadians to learn more about the causes of chronic disease and cancer. Next. So CanPath is a pan-Canadian cohort with over 330,000 participants. It includes 7 regional cohorts spanning all 10 provinces. So 5 of the cohorts are mature cohorts and have been in development for a long time, and 2 are just in the field now, and just still recruiting participants. So the earliest cohort was launched in, CanPath itself was launched in 2008 with adults aged 30 to 74 comprising the cohorts. So some of the individual cohorts have younger or older participants. The OHS, for example, has participants as young as 18. But the harmonized data that we share includes those who were aged 30 to 74 at baseline. And there's really close collaboration between the cohorts, and that provides a coordinated infrastructure, a large scope, and really enough statistical power to address important scientific questions, and also to capitalize on rapidly evolving technologies, including those that rely on big data like machine learning. And sort of that's where we see things going, especially with all of these linkages that we're working on. So for the follow-up questionnaires that we're planning, for example, we've established a data and harmonizing working group to make sure that the cohorts are all aligned in terms of what we'll be asking participants and how exactly the questions will be phrased. Next. The research platform itself is particularly important because, as we know, Canadians are living longer, so we're more likely to be diagnosed with a chronic disease. 1 in 2 will die from cancer or a chronic disease, for example. 1 in 2 Canadians will be diagnosed with cancer. And these diseases are associated, of course, with high healthcare costs, complex care, morbidity, and mortality. So they're major public health problems, and really a better understanding of their natural histories and their complex and interrelated causes is needed to bring about more effective approaches to prevention and early detection. So if we could prevent some of these conditions or even delay their onset by a few years, the impact on both the healthcare system and on quality of life would really be substantial. Next. So both diseased and healthy individuals were eligible for inclusion in the cohort. And then the prevalent cases support cross-sectional analyses and incident cases prospective analyses. So we're now at up to 15 years of follow-up. And so we've accrued many incident cases of some common diseases. And even sort of not the rarer ones, but sort of the mid-range and incident diseases as well. So given the prospective blood collection, the study also provides a unique opportunity to study gene-environment interactions. Next. The intent of CanPath is to engage participants in ongoing data collection over their lifespan, to follow them over time, both actively and passively through these administrative linkages, and to make all of the data that we collect, so the genomic, environmental, lifestyle, and electronic health-related data available to the scientific research community. And the derived variables that scientists have generated, including data generated from biologics, are then returned to the cohort to further enrich the data holding. So here you can see sort of the breakdown of the 330 CanPath participants. The majority are from the Ontario Health Study at over 181,000, followed by Cardigan in Quebec at almost 45, and then the Alberta's Tomorrow Project, Atlantic Path, BC Generations. And then you can see the newer cohorts in development. That's Healthy Future Saskatchewan and the Manitoba Tomorrow Project. Next. So the cohort enables both retrospective and prospective research. And, it enables a broad range of questions to be answered because of the comprehensive data collected from participants over a long period of time. So over 290 projects have been supported so far in research areas, including arthritis, cancer, diabetes, respiratory disease, heart disease, and more. Next. So all CanPath participants completed detailed baseline questionnaires and over 120,000 completed follow-up. At study entry, cohort members completed a questionnaire that collected information on sociodemographics, family history, health status, behavioral factors, lifestyle factors, and self-reported anthropometry. And a subset of participants provided blood samples and physical measures. So we've also collected follow-up questionnaires, and then when the COVID pandemic hit, we sort of mobilized quickly and launched COVID-19 questionnaires, and also serial dried blood spot collections were collected from 2020 to 2023. So we have up to 3 dried blood spot samples that were collected, and those were used for antibody testing, but are now also a good source of DNA. We also, if you note on the right there, we have, sorry, in the middle, we have data on medication use, and that's something that's not captured population-wide through administrative claims. So the administrative data only collect prescriptions for those over 65. So that's sort of a unique contribution as well. And all of this data has been harmonized nationally, and it's listed on the CanPath portal and available for linkage to administrative databases and available for researchers. Next. So we have 4 strategic paths that will guide us through 2027 to expand, enrich, transform, and promote. And while each of these paths is distinct, they're going to be taken concurrently to lead us sort of to the end goal, which is a healthy future for all Canadians. Next. So in terms of expanding, the initial recruitment of CanPath participants occurred more than 15 years ago. We're just celebrating our 15th anniversary now. And currently the average age of participants is over 65. So, you know, we recognize that the cohort is aging. It would be nice to bring in some sort of younger participants. We also recognize that we have gaps in our representation from populations that are historically underrepresented in population cohorts. And we're identifying and working with local stakeholders to reach participants from all backgrounds, including Indigenous communities, for example. And possibly, you know, you may have noted that we have representation from the provinces, but we don't yet from the territories. And so that's sort of something that we have an eye on for future development. Path 2 is to enrich. This centers around leveraging the investment that we've already made in the cohort to further enrich the platform and include linkages. So our work with HDRN, for example, would fall in part under this aim. So we're linking to the cancer registries, to the health data sets, administering additional follow-up. So we have follow-up questionnaires that we're planning to launch in the next year. And then at the bottom there, you'll note that we're planning on implementing an in-depth dietary and physical activity assessment. So Doctors Rachel Murphy and Susan Kirkpatrick just received external funding from CIHR for this initiative. So we're going to be collecting dietary data through 24-hour recalls and possibly also through a food frequency questionnaire in the next year or so. Aim 3 is to transform. So external researchers can they now have access to our biobank for samples, but we recognize that due to the cost of analyzing biosamples, researchers would be able to benefit from the biosamples if they were transformed into data that are made accessible. So that's part of our third aim. We have DNA source material for about 160,000 participants. We have genotyping data for about 1/3 of them, and we have imminent plans to genotype the rest. And then make sure that the genotype data is available to researchers. And then finally, the final aim is to engage. So we've made significant strides in engaging the research community and also fostering participant retention. And in terms of the researchers, this includes an increase in data access requests and in publications and in publicity. So we've launched webinars to keep researchers engaged, and also town halls, which participants benefit from. Next. So our commitment to filling these 4 strategic directions is led by a national team with Dr. Philip Awadala as the National Scientific Director, Dr. Jennifer Brooks as the Executive Director, and Trevor Dummer as the Co-Director. And then we have leads from each of the provinces. Next. CanPath's National Coordinating Center is based at the University of Toronto's Dalla Lana School of Public Health. And this is the NCC team. Next. So how are we working with HDRN? The linking of Canada's rich collection of administrative health data with the cohorts data really expands the amount of data that we have available. Next. So CanPath participants consented to administrative linkages, and they've recently been successfully linked to in a few of the regions to many of the data holdings, and that includes the cancer registries, the lab data, DAD and NACRS for the OHS in particular. And so we've really already begun to, pave the way, and that will expedite any new research project. So all the participants from OHS, for example, have already been linked to the data holdings at ICS. They already have ICANN numbers, and that will really expedite any new project. And with these linkage results, researchers can analyze health outcomes. And because they also capture a rich array of clinical data, the linkages also support health services research. So future disease endpoints will be captured as well. Next. Here's just sort of a depiction of that, how we have prevalent cases, incident cases, with blood samples collected before the incident cancer diagnoses. Next. So the mission, as you know, of HDRN is to bring together people and organizations, and that includes CanPath. HDRN has developed a data flow plan for linkage of CanPath data, and working with this network will really help navigate the process. So HDRN doesn't hold any of the data, but they're really working on simplifying the process and reducing the barriers. So conducting research that includes multi-regional data is otherwise a daunting endeavor. And so they aim to make this sort of a one-stop data access portal for researchers who really want to pursue multi-regional data. Yeah, so you'll hear more about the online support hub that HDRN has created, but it's really immensely helpful and will help researchers in the initial development of their project. And I'll just mention that it also includes CANU data, so the Canadian Urban Environmental Health Research Consortium. That includes data related to air pollution, water quality, noise exposure, light at night, et cetera. And that's been linked on an individual level to CanPath participants. And all of the resulting data will be able to be analyzed and accessed through a federated approach. So thanks very much. And now I'll pass things over to Carrie-Ann White from HDRN Canada.
Hi, and thank you so much, Dr. Vicky Kirsch. It's so wonderful to hear about the CanPath data and how we are working collaboratively to enable linkages. And really, it's with this type of work that the possibilities are really limitless for research. So I'm going to talk a little bit about how you can access the administrative data and the administrative data linked to CanPath. So next slide, please. So as my colleague Jody spoke about earlier, the Data Access Support Hub is a service for researchers doing multi-regional research. We are a coordination team of representatives from across the country. We have over 13 data centers that are a part of our network, and we help facilitate data access across provinces and territories and in pan-Canadian data centers like CIHI and Statistics Canada, and help navigate local requirements. So the data are available and accessible through the data centers, and we support researchers with this process. Next slide, please. So how do we simplify the data access process? Well, we provide coordination support. When you speak to our team, we help guide you in the right direction, provide you with the right contacts in order to proceed with your project. We also provide a suite of centralized resources and tools, including information on data assets available across our different member organizations and data centers. We also support different activities to harmonize data across provinces and territories, and continue to seek technological solutions to improve the data access process in Canada. Next slide, please. So this is just a little bit about our successes. So we are currently working on 20 active research projects. We have over 500 data assets, over 185 approved algorithms, as well as we're constantly supporting researchers with their queries on how to access data. Next slide, please. So what type of data do we hold? So we have administrative health data such as primary care data, data such as the discharge abstract database, so hospitalizations, the National Ambulatory Care Reporting System. So that's like day surgery and emergency visits. We also have some social data as well, and we're constantly looking to acquire new data sources such as CanPath and some other cohorts like CLSA, which is the Canadian Longitudinal Study for Aging. So there's a lot of different possibilities and data available through our member organizations. There's also opportunities to link your researcher collected data to our administrative health data, as well as CanPath data and other cohorts that and organizations that we work with. Next slide, please. So when we think about the linked data availability across different provinces and territories, right now for CanPath, we have data available in BC, Alberta, Ontario, New Brunswick. We're soon to get more in our Atlantic provinces. We're working towards the recruitment is in stages for Saskatchewan and Manitoba, and we're constantly working to increase the coverage and enable these linkages across provinces and territories. Next slide, please. I also spoke earlier that HDRN Canada and DASH provide some different innovative resources to support researchers along their journey with a data access request. So we have a data assets inventory that lists all the different data assets available by member organization and province territory. We also have an algorithm inventory. We have lots of information on privacy, ethics, and study design considerations. So be sure to check out our website as you're building your consents and looking to do and enable linkages for your cohorts. And we also host a web portal with centralized forms and tools to help you along that journey. Next slide, please. Okay, so how DASH works. This is a big figure, but I'll break it down for you. So essentially, when you want to request data and information and have access to data assets that are hosted by the member organizations at HDRN Canada, you can simply complete an intake form. So you sign up for a free DASH account on our website, submit an intake form with what your specific project objectives are, your data requirements, and then from there, we would review that information and set up an intake call with you and your project team, as well as the relevant jurisdictions to better understand your project and the objectives, and if we can support your work. From there, we help turn around a feasibility assessment and cost estimate for your project within 2 weeks. After which, you have some time to let us know if you would like to confirm and go ahead with your project. And once you're ready, we have you complete a data access request form. And in this data access request form, you confirm different components of your plan, whether your analytical plan, whether or not you're looking for linkages, which specific member organizations and data assets and data requirements that you're looking for, as well as other pertinent information to your project. We then work to analyze your project, setting up some meetings with you and your project team as the project moves forward. And then upon completion, we do data release and invoicing. And usually that's through a secure analytical environment, but it may vary depending on which jurisdiction you're working with. So with that said, that's a really great way to get support, especially in navigating the local requirements for data access. The coordination service that we provide here at DASH is completely free. So having an intake call with us and that consultation and getting some information about where you can access data, how you can enable linkages, all of that is free. And it only costs for the recovery of fees once you're actually starting to process your data access request. Okay, next slide, please. So if you're looking to access data, please don't hesitate to reach out to our team at dash@hdrn.ca. And you can also visit our website to review our resources and sign up for a free Dash account to submit an intake form. And we'll be happy to consult with you after that on your project. Next slide, please. And if you are looking to submit a project, some tips for a successful application, check out our website resources. We have a plethora of information, especially on privacy, ethics, and consent considerations. So make sure that you have appropriate consent to enable those linkages if you're looking to link your cohort to specific health administrative data or CanPath data. Make sure you are reviewing the data requirements in each province and jurisdiction, which you can look at in our website resources, as well as understanding policies and procedures across provinces and territories. And last but not least, please consult our team. We are here to support you. Again, these consultation services are entirely free, and we can really guide you in the right direction and have you in touch with the right networks to get your data. Next slide, please. So next, I'm going to pass it off to Dr. Aline Talhouk, who will give an overview of her experience working with DASH and accessing CanPath data linked to administrative health data. Thank you.
Thanks very much, Carrie-Ann. Hi, everyone. So my name is Aline Talhouk. I am an assistant professor of OBGYN in the Faculty of Medicine at UBC. And my project was perhaps one of the first that benefited from the coordination of DASH to link CanPath data with administrative data sets. So I'm happy to talk today about my experience. And so next slide, please. So in my research, I develop and I use risk prediction models to help direct identify participants that are at high risk for uterine cancers and then direct them to prevention and early detection interventions. And so these risk models, they take into account multiple exposures of risk factors. And there have been several that have been developed for endometrial cancer specifically, but none have been validated in a Canadian population. And in my team, we wanted to use these risk models in clinical studies, but we thought would be good to validate them. And the CanPath cohort was really ideal for that. And so even though a lot of the data that we needed at baseline to develop to predict risk was available in the CanPath cohort, many of the outcomes were not directly available. Specifically, we didn't only want to look at incidence of cancer, even though that's kind of the primary outcome that we're interested in. But we also wanted to look at things that happen between prediction of risk and cancer incidence that may modify the risk. For example, the cancer of the uterus could only happen to people who have a uterus intact. And so if something happens between the time we predict the risk and the time we look at cancer incidence that removes that participant from the risk pool, for example, if they had a hysterectomy, they would no longer be at risk. And so we needed to really look at also like surgeries that they may have had. Another example would be hormonal exposures. So some hormones can protect against endometrial cancer. So even though they may have been at high risk at baseline, when we do the predictions, because maybe they've had an intrauterine device inserted, which is known to prevent endometrial proliferation and cancer. we would need to know that to account for it in risk prediction and take that into consideration. So we really needed access to all of this information, which is not available in CanPath and requires the linkage to administrative data sets. There are two other things that we wanted to do which have not been done before, and that is taking into account gender roles. For example, even though people who have a uterus or are female at birth are at risk for uterine cancers. Sometimes certain gender roles, again, not thinking about gender as a binary male, female, but thinking along a spectrum, could influence the hormones that an individual is exposed to and influence the hormonal milieu of the uterus, which we know is really a very hormone sensitive organ. And so we wanted to look at a continuous gender index as opposed to a binary variable. And so we were able to do that sort of based on models that are already existing in the CanPath data. We adapted them to the data that was available on hand. We also wanted to take into account socioeconomic factors because we know that also those could really influence cancer risk. And none of the other models had done that. And so that was kind of one of the biggest advantages of using the CanPath cohort. So next slide. So our experience working with DASH has been really amazing and fantastic. And I kind of feel very fortunate to have had that partnership form at the time when I obtained my grant to do the study. So the DASH team helped us determine feasibility by first convening everybody from the various provinces, first to sort of discuss the project, and each province started, or each representative from each province started saying, well, you could access this through us, this is gonna work, or perhaps something like, oh, we have that data, but we don't have the resources to support it, or it's gonna be too arduous to get there. And so that helped us sort of decide which cohorts we were going to work with. And we ended up working with 3, Ontario, Alberta, and BC. Quebec, we were not able to access. Manitoba, they were still recruiting. The Atlantic provinces, there were just too few cases to justify all the work that would need to be done to get there. And so we just decided on those 3 provinces to work with. And DASH coordinated consolidated data access request. They gave us all of the information about what is available at the various cohort, what is useful, what is not. And again, we hadn't done this before ever. And so that was kind of very useful to have someone, in a way, hold our hands through the project. So that was really fantastic. And once we submitted that, DASH helped us move the project along. And so anytime we've encountered delays and we needed to reconvene to sort of identify any hiccups, DASH took care of coordinating all these meetings. Next slide. So, here's the slide where I talk a little bit about the positives and the negatives. So the positive is that linking to data across multiple provinces is possible. And so that is really amazing in of itself. It is now, with the support of DASH, more streamlined. And I only predict that it will get better with time, right? As we work through various issues, it will become easier and more streamlined. And so that is really a huge advantage that we have here in Canada. The negatives, I would say, it takes a while. So I think it's really important that you budget for the time that it's going to take. Just for reference, I got my grant in 2020 to access this data. It's 2024, and I'm just now starting to do my analysis. Now, of course, there was a pandemic in that time frame, so that should not be ignored. And it was also one of the first projects, so that also is not going to be a factor for many of the studies that are going to come later. But it still will take significant time. So may allocate 6 months to a year, or maybe perhaps even more. Important to note that the privacy regulations will differ at each province. And so because CanPath will, because each province has to adhere to the local guidelines, the CanPath data that you're going to get in one province is not going to look exactly like what you're going to get in another province. And the types of linkage that are possible in one province may not be possible in another. Similarly, not all the data is going to be, although a lot of those administrative data are kind of collected using harmonized or common data models, or have been harmonized, they're still not identical. So there may still need to be some level of harmonization that's done post hoc, like post data access. And so that's something that also needs to be kept in mind. And then finally, even though we want to develop models that can be generalized to the entire Canadian population, not all sites are easily accessible at this time. And I do know that perhaps, this is going to be something that is going to be a point of focus for the future.